To the There you go. Hello, everyone. Doing good again. Welcome to the third part of the five-part series of Thriving Together, a family's guide to navigating disability services. This particular webinar is on managing health needs in school. And the webinar series itself is a partnership between Pacer Center and Family Voices of Minnesota. I am so very excited to have everybody in attendance. Those who cannot make it, you can listen to the recording at your own time and your own time. And we hope that you're going to get a ton of information that is going to be useful to you in the long term and the short term, however you want to use it. All right. And then we are going to go over the agenda. And that is the welcome and a little bit of an overview of the series. You're going to meet our lovely, incredible presenters, and they're going to take it over with wonderful content and personal experiences that matches personal experiences, lived experience with the really legal educational framework behind individual health plans and behind 504s and IEPs, and what it's all about in terms of navigating health in schools. And I want to give a big thank you to Family Voices of Minnesota, and that is on the next slide. And a big thank you to people who contributed to this series that basically focuses on really bringing everybody together. So for those of you who are able to make it next week and the week after, we have two more Thursdays coming up with topics that are going to be very engaging as well. And we hope that you're going to find a lot of information that will benefit your family and your children in the long run. A big thank you to Family Voices for their partnerships and to all the other contributors to this series. And with that, I'm going to give it to our presenters. Yay.
Hi there, I'm Kate Edine. I am a parent advocate. I am also a special education teacher. This is my 24th year. And the past 9 years, I've been teaching in a federal setting for school. I absolutely adore it. I also have three 16-year-olds, and each of them have their own various health conditions, and I'll talk a little bit more about them a little bit later.
And I'm Heather Gadeen. I am one of the state school nurse consultants for the Minnesota Department of Health. I have a colleague over at the Minnesota Department of Education. I have 15 years of nursing experience, including various settings, most recently in school health. My experience in school health is about 5 years of school nursing experience at the district level. I actually got integrated and started consulting for before and after school programs. And then when a school nurse position opened, I applied for the position at the urging of my sister, who was a teacher in the district. I've been at the state for about 4 years, almost 4 years now, as one of the state school nurse consultants. And myself, I have two children with health conditions that we have had to navigate both in the medical sector and once they hit school age. And today we really want to chat about, we want to set up this webinar that we are providing perspective from managing chronic health conditions in the school setting, how to partner with the school and the health services team. But we also bring the perspective that although Kate is a special education teacher, I am a school nurse, the state school nurse consultant right now. We both have families that have students that have health conditions that we've had to navigate within the school setting. So we are bringing in our own personal experiences along with our professional experiences.
This is a little bit more about my kiddos. So I was a special education teacher prior to having my own kiddos. And I knew the skill of advocacy, but having my own kids taught me the heart behind it. Levi is the little guy in the wheelchair down there. He's in 11th grade. He has cerebral palsy, epilepsy, cortical vision impairment. He's also short bowel. He has scoliosis. He's got 40 surgeries behind him. He's medically complex, non-speaking. He uses an eye gaze for his augmentative communication device. He has an IEP currently for physical impairment and speech and language. And his twin brother Cameron is also in 11th grade. He has a 504 plan for ADHD and anxiety, social pragmatic communication disorder. And my daughter Anna is also in 11th grade and has another 504 plan for ADHD and anxiety. And she is also a type 1 diabetic, so has a DMMP.
Diabetic management plan.
Got it.
And I will definitely say that school nursing prepared me how to learn the things that I need to do when my kiddos had health conditions pop up and how to advocate for their needs in school. So my daughter Caitlin is in 6th grade. She was diagnosed with dyslexia and ADHD in 2nd grade, and as well as anxiety. And then this year, she was diagnosed with episodic depression. She also had a history of seizures that was later ruled out. She currently has a 504 plan for dyslexia and ADHD. And we did go through the IEP evaluation process, but did not end up getting an IEP. We ended up staying with the 504 plan. And then my son Jackson, he's in 2nd grade. He has ADHD, anxiety, and depression, and he is also has a 504 plan. All right, so we want to talk about a little bit about planning for your student healthcare needs when it comes to the school sector. So last week you had the opportunity to hear about how to navigate the healthcare sector. And so now we're going to talk a little bit about the school sector when it comes to healthcare needs. I really like this quote from a former U.S. Surgeon General, Dr. Jocelyn Elders. I actually had this in my office and I have it in my home office still, is that we can't educate children who are not healthy, and we cannot keep them healthy if they are not educated. There has to be a marriage between health and education. And really, this is so profound and true that healthy kids can be educated well, but you have to be educated well to maintain your health. So what is school nursing? Because, when we think about what is a nurse in a school, is that the school nurse? Well, there are some nuances, but school nursing is a specialty nursing practice, just like ER nursing or critical care nursing, OBGYN. School nursing is also a specialty nursing practice. And the goal is to protect and promote student health and to facilitate the students' optimal development and advance their academic success. School nurses help to bridge the healthcare and the education. They provide care coordination. They really do advocate for quality, student-centered care, and they collaborate to design systems that allow students and individuals and communities to develop to their full potential. When you think about what is school nursing or who's the school nurse, so a nurse is not a nurse is not a nurse. And that there's a big misconception about who the school nurse is. And so we're going to chat just a little bit about Minnesota requirements for who is the school nurse and other types of school health services staffing. Each state has different requirements, and these are in statute. But most of you are probably familiar with who a registered nurse is. You've seen them in hospitals, often clinics. They're licensed by the Minnesota Board of Nursing. They are considered a professional nurse, And then you also have a registered nurse who might carry their public health nurse registration or certificate. So this is a special registration with the Minnesota Board of Nursing. It means that we've had education regarding public health nursing, clinical hours, but some of the requirements is that you have to have your RN license as well. And then a licensed school nurse is a registered nurse. They have their public health nursing registration, but they're also licensed by the Professional Educator Licensing and Standards Boards. So the same board that provides teachers with their professional license also provides a licensed school nurse licensure for school nurses. So school nurses hold two licenses, I guess you could say, with the Board of Nursing and with PELSB. Each one has their own like continuing education and stuff that you have to do. So these types of nurses are called what is professional nurses. And so they have the authority to practice independently and to delegate nursing activities. They can provide comprehensive assessments and care planning, and then they can delegate nursing activities or tasks to a licensed practical nurse or an unlicensed person. So then going down to the licensed practical nurse. So again, it's a nurse. They're licensed by the Board of Nursing, but they work at the direction of a professional nurse. So an RN, an advanced practice RN, or a medical provider. They can do focused assessments as directed by the registered nurse, and they can complete delegated or assigned nursing activities, but they cannot practice independently and make all those independent decisions based on a full assessment. And then we have unlicensed assistive personnel, or we call them UAPs. And these are people that they don't have licensure, they don't have formal training. They might have some training. They might be first aid certified. They might have CPR training. They might have taken a medication course, but they're not licensed by the Board of Nursing or anything. You might, in a school setting, they might be a CNA or a CMA, or even we've seen EMTs where they have some of that education, but ultimately, again, they're not a nurse. Some districts call these health assistants, health office aides, paras, PCAs. Every district is different, job descriptions, job titles, so they might be called something different in each district. But they perform nursing activities as delegated by the RN. So one key thing that we want to talk about and really recognize is that resources vary by district. Every district is different sizes. Every district prioritizes staffing different based on resources available in their community, needs of their students, budget, etc. So in Minnesota, public school districts and charter schools operate under local control. And what that means is they get to make their own decisions. And we have a statute, and that statute requires a district to hire one LSN if the district has at least 1,000 students or more. So in our state, 34% of schools are required to have a licensed school nurse or contract with a public health nurse or a similar level of service. 49% of schools do have a licensed school nurse. However, only 26% of schools in those districts that are less than 1,000 students have a licensed school nurse. So again, like really thinking about where you live, the resources, smaller districts are less likely to have access to a licensed school nurse. And then again, reiterating that there are different types of nursing staff that are in districts. It varies by district. And so a nurse in the health office might not be the school nurse. It might be a practical nurse, an LPN. And then this data all comes from, we did a school nurse workforce snapshot in 2022, and that's where this is where this data comes from. There are different types of care planning or care plans in schools that nurses get involved with. And so that's kind of what we're going to focus on today. Depending on your students, your child's health conditions, you might have a child that has health conditions that could result in an emergency. So this could be a student with severe allergies that could potentially have anaphylaxis, or like Kate's daughter has diabetes where it could result in a low blood sugar that can be very dire. There might also be an opportunity to have an individualized health plan. And then, of course, 504 plans and IEPs. So what is the purpose of healthcare plans? Okay, really the purpose is to maintain the health status to optimize learning. We want to create a safe school and learning environment for those students. We want to maintain or increase their participation in their learning environment. We need to meet the daily health needs of those students so they can access their education. Obviously, if there's an emergency health need, we want to be able to respond appropriately, whether the nurse is available or not. And we want to ultimately foster self-care and independence as the child is developmentally age appropriate. I want to highlight this individualized healthcare plan. And I picked this one first to highlight because I think there's a lot of misconceptions about what an individualized healthcare plan is. So IHPs are nursing care plans, and they're written by a registered nurse, licensed school nurse, or the public health nurse. Individualized healthcare plans, they use the nursing process, and they're written in nursing language. This guides the care provided by nurses or those that the nurse delegates care to. And it's really an opportunity for nurses to utilize a plan that combines all their healthcare needs into a document to organize their care. So it creates some goals for the student, but it also has an evaluation component of, are we working towards those goals? Are we meeting those goals? So unless you're in the healthcare sector, in a hospital setting, this would be like some nursing diagnoses and nursing care plans. So translating to the hospital setting, if a patient is at more increased risk to fall, the nurse might implement like wearing those yellow grippy socks, or ensuring the call button is close, doing some patient education about falls and stuff. So this equates a little bit to what this is. The IHP may include an emergency care plan, which we're going to talk about next. And it can be referenced in a student's IEP or 504 plan. In Minnesota, IHPs are not required. And when we educate school nurses, we really say that these plans should be reserved for students in which they have some more complex needs and you're coordinating a little bit more, or you have some very specific goals that you're working with that student. So it might be some of that age appropriate, once they are developmentally ready to work on some of those skills for self-management, or some creating goals with the parent and the child. So again, I just want to reiterate that this is a nursing care plan written by the nurse. But this term might float out there because people, they say it at like, oh, it's the individualized health care plan, but they might actually be referring to different plan. The most common care plan that we see in schools is an emergency care plan, or emergency action plan, it might be called. And these are plans that oftentimes you parents will get from a provider. And they give, so these are for students or children who have a known health condition that could result in a medical emergency. They're written in a fashion that they use layman's terms, easy step-by-step directions to follow of do this when this happens, so that we know those actions to take when there's an emergency. It leaves little choice, and just provides the direction. These types of plans help to direct our staff training that we do in schools. So if a student has seizures, and we'll provide some seizure first aid training, but this student has this medication and their rescue medication is to be given after 3 minutes versus maybe another person is 5 minutes. So this directs that individualized education and staff training for the student's needs. These plans could be written by a healthcare provider. Often we get plans from healthcare providers, but they can also be contributed to or added to with the nurse. These plans can be referenced or included in the IHP, IEP, or 504 plans. So again, I have an example here of the seizure action plan, but another common is like the anaphylaxis plan or the diabetic management plan. So what is the role of the nurse when it comes to the emergency care plan? So
Heather, there's a question in the chat. Could I ask super quick?
Absolutely.
Okay, so Addie's asking, would challenges related to PICA warrant an IHP to set goals around reducing ingestion of non-food items, or an EHP if they have a history of ingesting more dangerous items?
Yeah, so the IHP is a great plan to have for setting those goals around reducing the ingestion of those objects. Yep. So there's a lot of care planning, setting goals and outcomes that can be measured. The ECP, you can have both. The ECP would be warranted if there's a medical emergency. And so if it might be that if the student ingests this, then we're going to call 911. The ECP also helps to outline the communication plan for if the nurse isn't there, or if the nurse is like busy with another person. So there might actually be a warrant to have both, but it could also be addressed in the IHP, and then the nurse can communicate it to the people that they delegate to. So it's a yes and it depends, and it might warrant more conversation to see what's the best for your individual student in the circumstances. There's so much in school nursing that in schools in general that is clear as mud, as we like to say.
Addie found it very helpful, found your response so thank you. Thank you so much.
Okay, so what is the nurse's role? So we are the care coordinator and collaborators. So we might add to the plan, because so many times when the healthcare provider provides a plan for school, there's little modifications that need to be made. This building is not the same as this building in a district. I mean, if you have multiple kids in a district, or if you've transferred schools, you fastly learn that every school is different. And so we make those little modifications based on what the emergency response plan is for that school, or maybe where emergency meds are maintained. The school nurse might write it if a student needs an emergency care plan, but one didn't come from the healthcare provider. The school nurse can write their own. It can be a nursing care plan. They might review it, and again, they might add things to it. One plan that we see specifically added to quite often is the seizure action plans that come from providers. And that is really because of the laws that are in place about the information that's required to be in a seizure action plan for the school setting. And most of that information's not in there when it comes from the healthcare provider. We're the communicator of the plan. So this is often to the classroom teachers, the health office, if there's other staff in the health office, if there's building backup staff. It might be to the food services staff for students with allergies. So we help communicate that plan for those people who need to know. We'll educate teachers, staff, etc. And then we delegate nursing tasks. So we might delegate medication administration to be able to implement the plan, to be able to give that emergency medication. And then also we're the evaluator of the effectiveness and outcomes of the plan. And this is done also with parent involvement, because obviously we can evaluate what is going on in the school setting, but it still impacts the family, and parents know what's going on too. I see some questions here.
Yes, and one was related to disagreement between parents in terms of medication. And I gave my response. I would be curious to hear yours. And then the other one, Jessica is asking, if the nurse is not available, what is the role of the teacher in emergency situations?
Yeah, great questions. So when one parent is on board for medications and one is not, that is tough. Oftentimes, a nurse will not know that parents are in disagreement. And so if one parent brings in a med consent form, it's signed, they'll administer the medication as prescribed by the doctor. And then if they hear that the other parent doesn't want it, then typically the administrators get involved. And yes, as Anya said, there needs to be agreement between the parents. And then role of the teacher when the nurse isn't there, or maybe the school doesn't have a nurse. So the emergency care plans, they should be detailed enough to when I'm going to do this, this, and this. And then they should add a section of what to do if the nurse isn't available. And it might be that the next step is to call parents, or in these situations, I'm going to call 911. So that should be outlined in the plan. And then there should be a follow-up, the loop back circle of informing the school nurse, if they're not available, about what happened and what the decisions were made, because then the nurse knows what's going on and can loop back in and follow up if needed. So, and then again, in districts that don't have a school nurse, it is the responsibility of a district to provide health services for students. And so how districts do this without a nurse, really, it kind of varies. And some districts might hire a registered nurse, or they might have someone who maybe a health assistant that's or a health office person that is an unlicensed person. And then, that person really should be following provider orders. And then you have to have that good partnership where parents can come in and do the education for the staff versus a nurse doing the education for the staff. So there are differences in districts that are lower resourced, that there's probably going to be a lot more parent involvement to be able to effectively meet the student health needs. Did I answer that question well? Let's see.
I believe so. Just let us know. Yeah. Yes. Okay. Yes.
I feel
yes,
like
yes,
okay.
yes.
I feel like this
had a follow up to the previous question about, with the parents' disagreement and have a layer of protection to be required as a signature from both parties. And that would totally make sense to have that. Mm-hmm.
Yeah, and that's a district, again, local district decision making. Every district will be different, and so that's those are nuances that have to be decided by the district and between parents.
Yeah.
Okay. Section 504s. So 50 Section 504 is a federal law that assures individuals will not be discriminated against based on their disability. It's written for students who are assessed to have a physical or mental impairment that substantially limits one or more life activity. It's written in terms of what the child will receive to have access to education. So Section 504 is about leveling the playing field, creating that handicap for that student to have access to their education. Schools will request a medical diagnosis from a healthcare provider to assist in determining eligibility. It does require, so even though you get that provider's medical diagnosis and note, it does require a school evaluation to determine if there is an educational disability classification. These result in accommodation plans for general education students. And again, they were designed to remove barriers for learning, to level that playing field. It does provide some protections. It's a legal requirement that districts and schools and staff are required to follow through with, outlined for that student. It can be changed. And oftentimes there is good reason to check in. I know for my daughter this year, we checked in at parent-teacher conferences. We had her 504 written before the school year. And then when parent-teacher conferences came around, I chatted with her. I'm like, oh, do you think your teachers are following this? And she's like, oh, no, not in this class, not in this class. And when we went to parent-teacher conferences, we just chatted with it, and the teachers described, oh, I keep it in mind and everything. But then they took the opportunity to ask my daughter and said, well, what do you think could be different? For my daughter's circumstances, it was she wanted her preferential seating because she got distracted by students when she was sitting more towards the back. Criteria. So individuals with disabilities as a physical or mental impairment that substantially limits one or more major life activity. You have to have a record, and then it has to be regarded as having an impairment. So when we define substantially limiting, we define this and we want to interpret it broadly and inclusively. This includes both episodic occurrences and those who might be in remission in their health condition. It does not include mitigating factors. So that is not relevant. So if they are getting treatments or they're taking medications and their medications make things better, they have hearing aids, those, it doesn't matter. It's still considered a substantially limiting disability, and then they can still qualify for the 504. So the process for 504s is that there's a referral, and this can be initiated by parents, teachers, school nurses, community agencies. I know for my children, I initiated it for both of them. But when I was a school nurse, I also talked to some parents and said, this is some information about 504s. Is this something you want to consider? And I had some parents who are like, oh yeah, I want to hear more. And other parents are like, nope, the healthcare plan is just fine. And then there's an evaluation, and this includes gathering information. So it might be information from the parents, from the teacher, could be attendance records. It does include some healthcare provider notes and the diagnosis, and then determining the eligibility. And this is where the team meets, and oftentimes they meet with the parent too. They might look at materials first, but typically it's an inclusive meeting. And then they determine the eligibility. And then from there, they will go forth and set some accommodations. One thing I want to note here is that every district varies greatly about who their 504 team is. Some districts, their 504 coordinator might be the school counselor. Some, it might be the principal. And some, it could be the school nurse. It varies greatly by district. So just because one district, or you talk to one parent and they're like, oh, you have to contact the counselor for this, and another district is like, nope, it's the principal. You just have to ask those questions about who their 504 coordinator is, and just, again, ask the questions. Also, if you feel someone is missing from the 504 team, you as a parent can request that. When I will say that nurses are often left off the 504 team. Don't ask me why. It's just kind of been the practice in schools. And my experience with this is that my son is on some medications, and his 504 plan, while it doesn't address, he doesn't take medications in school. He's got some medications that in the health census, or when we registered him, we write down all the medications he's on and all that information. He's got some medications in which we have to watch for some signs and symptoms of tardive dyskinesia. And so when the 504 team originally met and the nurse wasn't on the team, I said, oh, could we please have the nurse on the team? And they're like, oh, we don't usually include our nurses. And I said, well, for this situation, he's on some medications which the school nurse knows about, but isn't necessarily pertinent to his accommodations in school. And so they respected my request, and they brought the school nurse onto the team. Now, my daughter, her 504 is more so related to her dyslexia. And so in that instance, we didn't necessarily include the school nurse. However, after the fact, I chose to share the 504 plan with the school nurse because I wanted to make sure that the health office was aware that there's a 504 plan. I can share that sometimes, and not by malintent or anything, but there might be some 504 accommodations, especially related to school refusal or some mental health. And if the accommodations or the plan is not shared with the school nurse, and that student comes to the health office and they're vomiting or whatever, the nurse might inadvertently send that child home, and that wasn't the plan for the student. Maybe the plan was for the student to go to the counselors or the social worker before they get sent home. And so it's key to make sure the plan gets communicated to all everyone who's needs to be involved in that, in managing that your students' healthcare needs. Were there any question? Okay.
So Heather, one question that did come up, basically, and I had it happen with conversation with parents too, but let's say the parent would believe that, the teacher could perform certain duties that the nurse should perform, but she's not available. It's a piggyback on Jessica's question. How would people go about that? Like any recommendations? And the school says, no, we cannot do this because the nurse should be in charge of performing those specific interventions.
Yeah. So, and I have this at the very end, and maybe I should have put it more so at the beginning. So, when we know that you as parents, you manage all the needs of your child when they're at home. And so you would think that, oh, the teacher can manage this, the secretary can manage it. If I have to manage it as a parent, like anyone can manage it, right? The difference is that in the school setting, we're all working in our professional roles. We're not parents. And so when we're in our professional roles, there are different things that we have to follow. For nurses, we have to follow the Nurse Practice Act. If we would just have a teacher do this or that, they could potentially be practicing nursing without a license, which is against the law. And so that is why nurses, we delegate nursing tasks, and delegation is a really nuanced thing, and not something we really talk to parents about, but I'll just, a brief thing is delegation is You're assigning and transferring the authority of doing one nursing task to another person. It requires appropriate training. It requires a competent person who can perform the task, who accepts the task. And then it also requires some supervision and monitoring to make sure that the task is being completed appropriately, or that person is following through and not deviating and going off plan. So there's a lot of nuances that go into delegation. The nurse is the only person that is able to delegate nursing. The professional nurse, not an LPN, but the professional nurse, so an RN, the licensed school nurse, or a public health nurse, are the only people who can delegate nursing tasks. So when a provider writes an order to a parent saying, oh, give the medication and everything to the parent, they're giving you directions. When a provider writes that same order to a nurse in their professional setting, it's being delegated from the provider to the nurse. And then the nurse has to decide if it's appropriate to delegate this to someone else. A lot of those decisions are based on, is there an expected outcome? How stable is that student or their health condition? What is the environment? Are the staff that we're training, are they competent? Do they even accept and willing to do it? So it's way too nuanced to get into for everything. But the takeaway is that in the school setting, we're all acting in professional roles. And because of that, we have to follow the laws, the Nurse Practice Act, and we need to ensure that staff are not accidentally being asked to practice nursing without a license. I hope that makes sense. Okay, so
No,
the school nurses.
Yes, thank you. Thank you.
The school nurse's role in a 504 plan is that, again, the nurses are the health expert in the school setting. So they kind of serve as that bridge between health and education. They can help translate some of the healthcare talk, and they are able to help describe how a major life activity impacts the development, how it impacts learning. And then nurses can help to put together some accommodations, especially when it's related to health and nursing. The IHP emergency care plan or emergency action plan can be referenced and integrated into the 504 plan. So on the bottom, there is an example of sickle cell. Oftentimes, like think about anaphylaxis or students with severe allergies. You might say, you might see some accommodations in elementary about, notifying the rest of the classroom about an allergy, so safe snacks come to school or students don't share. And then it'll reference that this student has an emergency care plan and an EpiPen will be administered or something. So it can be referenced. Those other care plans can be referenced within the 504 plan. And then there's the individualized education plan or IEP. And then for birth to 3 years old, the individualized family service plan or IFSP. And so this is a federal law that makes available free and appropriate education to eligible students. So these are our special education students with disabilities. And again, it's so that all students can have access to public education. This is a written legal document that describes the educational needs, which details their specialized education, and it also includes the related services. So any nursing, speech, OT, PT. 504 plans they also do include related services too. This is written in terms of what the child will achieve and the supports the child will receive to meet those goals. So it's that specialized education plan, and then it includes any of the related services that they might have. I do want to note that if a child qualifies for an IEP for speech, for example, but they also have a severe allergy and they need an emergency care plan for potentially anaphylaxis, and they need those nursing services. Even though they qualify for speech, because they have an IEP, the related services can be written into the IEP. They do not need both a 504 and an IEP. 504s are for our general education students, and IEPs can cover it all, and they're for the special education students. The nurse's role in IEPs is they are often asked to complete a health assessment. So the IEP team will meet, they'll determine the need. If they need a health assessment, they'll get the permissions from the parent or guardian. This is all part of the due process. Yes, it's cumbersome. But it's the legal rules that you have to follow to be able to do all these things. And then the nurse completes that health assessment. It might include a records review, requesting diagnoses from the providers. It might be vision, hearing, or other screenings. And then the nurse's role is to interpret and synthesize that health-related information, and really help to educate the team about what that health condition how it impacts learning and what it might mean for the school environment. To note here is that really the nurse is the most appropriate person to be looking at the health records and synthesizing this health information. In many districts, again, resources vary, roles vary, but oftentimes I have seen that assessment specialists or someone else in the team is doing the synthesis of the health information. And while they might be doing a fine job, really the best person for this is the nurse because they have that background. And then based on the evaluation report, then that's when, if the student has health needs, then you might write in nursing services in the accommodation section. And if nursing services are provided, you might also see those minutes in the service grid. So some IEP documentation, or what you might see included in your child's IEP, is that it might include what nursing services will be provided. It often refers to an IHP or the emergency care plan, and it might provide rationale for the nursing minutes that are documented. So here's one example. Again, they're very different depending on student and their needs, but due to Joe Sally's cerebral palsy, nursing services are needed to provide chronic disease management. A health assessment will be completed annually, and when changes of health status occur, the nurse will train staff in first aid for seizures as outlined in the health plan. Emergency medications will be administered to the nurse or is delegated following medical orders. The professional nurse will provide training, orientation, and supervision. And then the nurse will provide instruction regarding care of an emergency plan for the baclofen pump. I will say here that it's usually better to reference an emergency care plan or other health plan or IHP instead of writing all the details in there, because if your child's emergency care plan would change, or like medication dosage, for example, would change, it requires a whole IEP meeting and all the due process and everything. So it's better to just reference the plan and keep that vague, like following medical orders, because then you don't have to convene the team to change those specifics of the health plan. So what plan do we go with? What is available for my child? So if you have a child with health conditions, really anyone can have an IHP, and that a nurse is not necessarily just going to write an IHP for every single student. It takes time. There's goals. You have to, if a nurse writes a care plan, you have to follow through with the care plan. Otherwise, it would be considered negligent. So if that is something that your student needs, requires some communication and making your wishes known. Or it might be an emergency care plan, that it's that health condition that could have that potential emergency. And so then we're going to write that emergency care plan. Again, that emergency care plan might come from the provider, and then the nurse could contribute to it. Or maybe it's you don't have one, and then the nurse develops it. Or you have the 504 option. So you have your general education student in the regular classroom, and then you go through that process. They're eligible for it, so then you develop the 504 plan. Or if they're not eligible for a 504 plan, then that's your opportunity to go back and ask and say, oh, would an IHP be a better fit, or would an emergency care plan be appropriate? And then your IEP, again, eligibility has to be determined. And if you're eligible, then you might have the IEP. Nursing services might be written into it if you have those needs. And if you're not eligible, then you might, again, go back. Is a 504 better? Or is an IHP or ECP needed? So there is some options out there, and you might have a student that has multiple plans, again, because we talked about how they can be referenced in each one. All right, so school nurses and our role in care coordination. So what does care coordination mean? Well, it's an opportunity to develop and implement healthcare plans to provide direct care for chronic, episodic, or emergency care concerns. It's an opportunity to collaborate, to communicate with both all your care providers. So the community, the school, the healthcare providers. It's that communication of making sure that your child's needs are met in all areas throughout their school day. And then it's also an opportunity for us to educate students on their own self-management as they get a little bit older. So it's so fun to hear some school nurses, especially where they're the district nurse, and they get to, they have this student who starts in kindergarten with diabetes, and they're, just newly diagnosed, and then to watch them all the way and graduate as high schoolers, and they're completely managing on their own. And that's really the goal, is that we as nurses, as parents, we want our children to become independent and start advocating for themselves. So how can we partner with the school so that we have positive experiences? So we know that when we are letting our kids go to school and they have these needs, these can be very big needs, health needs, that there has to be a level of trust, and that trust doesn't just develop overnight. It's not, I don't just hand over my child to you and oh, you got it. I'm sure some of us have had really bad experiences, and some of us have had good. And I know even Kate will talk about how she's had experience where it goes from bad to good, or maybe there's a rocky period in there. It takes time to develop that relationship and trust. And one of the ways to develop that relationship and trust is clear, consistent communication. We always want to assume positive intent. The other thing is, and I italicize this, is we have to share realistic goals. What we do at home is not always feasible in the school setting with the resources that the school has. A very good example of this is monitoring continuous blood glucose monitoring with the Dexcom app. Schools are not a hospital setting where we have a teletext that are watching the whole time. We have continuous blood glucose monitoring is an excellent development in diabetes management. But it's a tool. And so part of that is that, you know, we still want to teach our teachers, our students, that these are signs and symptoms of low and high blood sugar, that we're not just focusing on the number. And again, it's a tool, but having those realistic goals, that it is not realistic to have a nurse sitting there and watching 5 iPads with just numbers all day, because they have numerous students coming into the health office. So creating those realistic goals. And then mutual understanding and respect for each other's expertise, roles, challenges, and limitations. I can share that it takes about 3 years to really understand the school nursing practice. The first year, you're like just learning as things come to you. It is a different type of nursing. You're coming oftentimes from a clinic or a hospital setting, and all of a sudden you're learning. Like nurses, we like our alphabet soup. We like our abbreviations and all of that. But then you come into the educational system and you're like 504, IEP, and all of that stuff. And you're like, what? So it takes time to learn that. In the first year, you are really just responding. And then the second year, you're like, oh, I can start anticipating that. But then something new pops up that I didn't have the first year, and you're still learning. It really, school nurses, it takes about 3 years to really get a good grasp of this specialty practice. So just understanding that and giving grace. And then there are some challenges of the settings that we're in. Again, what we do at home, maybe how we do this tube feed at home, it has to vary and be done a little bit more clinically in the school setting because of infection control practices or different things. So just understanding that and asking out of curiosity, asking those questions and assuming positive intent.
Heather, we got a question.
Yeah.
And it is related to, so Divya has, her child is on an IEP, initially written for autism as a main disability. However, a recent diagnosis of high heart rate. Does the school need to be informed? Does the school nurse need to be informed? And will there be a need for an IHP or ECP to be put in place?
So I would for sure communicate that with the school nurse, definitely. And then as far as an IHP or ECP, it depends. If it's high, so tachycardia, that probably isn't going to result in a medical emergency unless you're going into an arrhythmia, which might be the case for your child. So it depends. But I would definitely inform the nurse in the very least. And the nurse knows like, oh, if this child comes in, I'm going to check their pulse. I'm going to watch for or do my assessment for what could be cardiac related. So definitely I would inform the nurse, and then together you guys can decide if another type of care plan is needed.
And it speaks to the communication and the partnership. Mm-hmm. So you start that process early on, which is great. Thank you.
Yeah, great questions. All right, I wanted to talk just a little bit about FERPA and HIPAA. So FERPA is the federal law that protects personally identifiable information, including student educational records. Student health records are part of educational records. It protects the privacy of the students and the parents by restricting access to who has access to these school records. It does allow people to share pertinent information for those who have legitimate educational interests. So need to know. So this might be the school nurse sharing with the teacher or the kitchen staff that this child has an allergy to peanuts. And so this is their emergency care plan. And, every school does something different, but maybe they're sitting at a nut-free table or something. It does, parents do need to sign a release of information to talk to a healthcare provider or request medical records. FERPA is more restrictive than HIPAA. And FERPA trumps HIPAA in the school setting. Then we go to HIPAA, and this is the Health Insurance Portability and Accountability Act, and this covers all identifiable protective health information. So we call that PHI, and this is anything that could be transmitted by a healthcare entity or business, and so it could be electronic, paper, or oral. And this law requires organizations to have appropriate safeguards in place to protect privacy and to limit who can have access to the information and who they disclose information to. So this applies to healthcare providers, clinics, hospitals, etc. So that healthcare sector. FERPA applies to the school sector. Schools can be have the restrictions of both FERPA and HIPAA when they are engaging in like Medicaid billing or Medicaid covered services. So there is a little bit of overlap and intersect, but primarily FERPA is what covers schools. And then I will say, there's a lot of confusion about this. Healthcare providers don't always understand the nuances. So oftentimes you will be asked to sign a release of information for both the school and the healthcare provider. Because of HIPAA, a lot of healthcare providers, like they have their like, oh, we need my clinic's ROI signed out because it has all of our protections written in it. And then schools are like, no, we need our ROI filled out because this has all the legal language for FERPA. So do not be surprised if you are asked to fill out both at the clinic and the school. It seems cumbersome, but it really is. It's a broken system. It's not broken. It's the realities of the system. Everyone's just making sure that they're following all the rules that they are governed by. And then I just want to note that, again, we kind of talked about this, but when a healthcare provider writes an order for a student to have a treatment, medication, et cetera, in school, they are delegating to that nurse in their professional role. And so a nurse has to be able to communicate with the provider in order to provide safe and effective care. So it is important to sign those releases of information. Sometimes you might see like medication consents have a release built into it. But that is so that that nurse has the ability to go back to the provider and say, I need some clarification about how you wrote this order. You wrote this as, it's just PRN, but I don't have exact reasons why I would give it in the school setting. There's just a little bit more restrictions in the school setting than maybe what you would do at home. And so just allowing that communication, it might be the nurse might need to ask questions or communicate and be like, I think I'm seeing some side effects and stuff like that. So that's the importance of having the release of information. And we did link here two really great resources that try to explain the differences and the overlap between the two. Okay, so now we wanted to share just a few practical strategies. And Kate's going to give some examples. I'll share a few of my examples. But really some of it comes down to communicating clearly and collaboratively, going in with curiosity, asking those questions, assuming positive intent, preparing for the meetings so that you have the opportunity to clearly communicate what your expectations are, what your students' needs are, and then being open to having that discussions about, okay, how can we meet your students' needs with the resources that we have? And then the ultimate goal is that we want to have a student who is well supported for their healthcare needs in the school setting. We want to have happy families. We want to have safe schools. So having that partnership. All right, take it away, Kate.
All right. My main tips for advocating for your children in school. Number one is educating yourself. Educating yourself on your child's educational rights, and especially if your child has an IEP or a 504, reading up on those procedural safeguards. You are sent either a huge packet with your first IEP or with your first 504 plan. And it looks like a lot of legalese, and it is, and it's hard to understand. But knowing those rights are super important. And so I know Pacer has a lot of great information about it, and we're going to link some of that as well. Knowing your rights and what your child's rights are is super important. And then also just knowing everything about your child's conditions that you can. I just popped a couple books about my own child, especially my more complex child, Levi, who has just so many different conditions. Spastic quadriplegia is his main diagnosis. I wrote this book with Marcy Ward from Gillette, and it was super fun, but I learned so much about CP writing that book with her, and it just really taught me a lot that I didn't understand. And so I was able to then share that information with the school nurse. And knowing your own child's condition and sharing that information with the educational professionals that work with your children is solid gold. As a teacher of 24 years, I have worked with thousands of children who have had ADHD. Not one of them has been the same. And any parent that reaches out and gives me information about their child and says, this is how ADHD shows up in my kid, that is gold to me because I can then use that information to teach their child better. And so if you can create any sort of binder, this is one binder for one child. um, that's just educating yourself so you can educate the people who work with your kids. That is huge. And then be proactive, not reactive. It is very easy to become reactive in a situation where you feel you're outnumbered or you feel like you have to be defensive. And if you're being proactive, usually you don't have to become that way. Over communicate, provide all the resources. My kiddos are now all in 11th grade, and so our elementary days are over, our middle school days are over. We are now in high school, and they are advocating for themselves. And it's a great place to be. But going back into some of the resources I made when I was being the advocate for the majority of the time is just taking a trip down memory lane. But I would make all about me sheets for all of my children, and we would provide those in August before they even got into school. And it would go over my kids' executive functioning strengths and their weaknesses. And it would give teachers a heads up. They wouldn't even need to meet my kids, and they would already feel like they knew my kids. And it would just really give them like an overview of what my kids needed to work on and what they could do. My type 1 diabetic, I would provide boxes of supplies. We would meet with the nurse and we would go over this is what my diabetics pump looks like. This is how it works. These are extra supplies for you. This is extra insulin to be kept in the nurse's office. This is all of the contact information you need for us. And we would do charts that would basically say if the arrows look like this this is exactly how many fruit snacks to offer. And all of that is so individualized. And nurses would never, they would never know that. But as parents, you're the expert on your child. And if they have a color-coded sheet that you've created, being proactive, it just makes everything super, super simple. And the other thing is be super thankful for everything that the staff does for your children. Being a special education teacher and case manager, just receiving just a simple thank you for working with my kid is huge. Every winter break, every end of year, especially for Levi's team, Levi has up to 14 members working with him. He has one-to-one para. Sometimes he would have one-to-one nurses. And we would definitely send thank yous because I know they're changing my child 5 times a day. They are pulling him out of his wheelchair. They are dealing with a lot. And so just a thank you goes so long. And so those were my main advocacy tips. You can go to the next slide.
Well, I just want to reiterate what Kate said. Actually just gonna go back to your slide.
Okay, sure.
So, um, knowing your child's condition and communicating that, I know not for my son, we went through, well, we had a lot of different services. I started creating, and this is the nurse in me, okay? But I started creating my own mini, like brief health history for him. But I did it from the perspective of like, okay, we started in kindergarten and he had a terrible year in kindergarten where he ended the year where he was only going to school 3 days a week because he knew he had terrible separation anxiety. He knew exactly what to do to get out of school. And he wanted to be home where mom was because I had transitioned to this job and was primarily working from home. My sister chose to homeschool her daughter, my son's best friend. And so he wanted to go to school with Auntie. And so he knew exactly what he had to do. He destroyed the classroom and like to get out of school. And but then like fast forwarding of why we tried this medication, it didn't work, why we increased it, where we increased it. This past year, my mini health history came in at such a crucial time when we were coordinating with sleep medicine and everything. And even just quickly jogging the healthcare providers of like, oh, we've already tried that, or this is why we increased, this is why we went back. For those of you who were on last week's webinar, I think they talked a little bit about that, of having like a little chart about who all your providers are when you have different specialty providers that you're coordinating with, and what their role is, what the diagnosis is. That it can come in very handy. When we created my son's 504 plan this year, I handed that to everyone. Now I have it printed and I'm like bring it to all the meetings and school and healthcare, and it's come in really handy, and it helps to jog my memory too. And then I just wanted to reiterate the showing the staff appreciation. Teaching, nursing, principaling, they're all actually very thankless jobs. They, teachers, nurses that work many hours. They are not a 9 to 5 job. You think that the school nurse goes home and like clocks out. Nope. I can tell you that school nurses are working just as many after school hours as teachers are. And so they're thankless jobs. Their jobs we don't get tips for serving or anything like that. A card, just an email. One thing that I've started doing, my daughter has a really great relationship with her school counselor. I have started paying the counselor compliment and CCing the principal. Administration needs to know their staff are doing great things too. So showing that appreciation. Give a little shout out that Nurses Week is the same week as Teachers Week. So don't forget about your nurses. Um, let's see. Oh yeah, Kate, sorry. I was just,
Oh,
wanted to
yeah,
add to yours.
sorry. That she made gifts for all 20 members of the team for each holiday to teach her son to have gratitude for everyone who helps him.
Mhm.
Yeah. And
Absolutely.
the also teachers and nurses email me back at 9 p.m. at night. I don't expect it. It surprises me every time. So yes, thank you. Yes, yes. And one thing
Yep.
that I would like to add in terms of like knowing your child's condition, also as a parent connecting with other parents who are going through the same journey, walking that same or potentially ideally 3 years ahead of you on that journey. That's ideal. And that's something that Family Voices of Minnesota provides through parent support groups. So I'm going to put the link to their parent support groups here for those who are interested. And they do have a lot of support groups for parents with medically complex kids. So that's sorry. Go ahead, Kate. Sorry.
Oh yeah, absolutely. I was just gonna kind of do an overview of each of my three kids' kind of experience with nursing in school, and kind of health services. So Cameron and Levi were born premature, and so they both received birth to three services right out of the NICU. And in this picture, they are going to their first day of preschool. They both were in wheelchairs for the first day of preschool. Cameron had broken his leg, so they both went to special education preschool, birth to three. But before or for 3 to 5. Birth to three, they were receiving PT, speech, OT 3 days a week at home. And then they went to preschool and they both had the IFSPs. And then in preschool, Cameron did kind of graduate from some of that and he just kind of hung on for some gross motor. He was very delayed in his gross motor, but he kind of graduated out of that. And then in kindergarten, he was just really quiet and just kind of he graduated completely off of a IEP once he hit 5. Like he no longer qualified. And so I happened to work as a special education teacher in his same school, kindergarten through 5th grade. And so he didn't really need any services. He did qualify for a 504 plan in 4th grade. He was diagnosed with ADHD, inattentive type, and anxiety. He was so quiet and so inattentive that he really just really kind of went under everyone's radar. And he was really kind of, I would say, overshadowed a bit by his brother's needs. So he skated by and really his 504 plan spoke to mostly his need for preferential seating and it spoke to his anxiety where he would internalize if anybody around him was called out. And so we had to really make sure that the teachers knew not to call around, put him next to kids who would be called out. And so I had to talk to him and very specifically know him well enough to know when he came home and he was upset and he would tell me about the kids around him getting in trouble. And so then I would have to translate that into 504 language enough to know he's feeling like he's in trouble because the kids around him are in trouble. And so that language in his 504 plan actually followed him through 5th grade, 6th grade, and that was COVID year. So he wound up halfway through 5th grade doing homeschool and then all of 6th grade online school, which worked great for him, and then went back to school in 7th grade. And so he then really did well, kind of making that transition. But at about 14, we started realizing that his anxiety meds were doing nothing. And we're wondering, is this really anxiety or could it maybe be autism? And so he decided himself that he wanted to really look further into it. And so he went in for a full neuropsych eval, and the evaluator talked to him a lot, and they came up with, although he met most of the autism qualifiers, it was all under a social, only social things. And it was very much a written language disorder. And so he came up with a social pragmatic communication disorder. And it only affects Cameron very specifically in written language that is pragmatic language. And so his 504 very much speaks to Cameron is not expected to do pragmatic assignments. And so knowing his needs and explaining those to every English teacher he has had in high school has been a very unique process. And explaining to his teachers what social pragmatic communication disorder is, because it is a newer diagnosis in the DSM-5, has been an interesting process. But his 504 is mainly come into handy for extra time on those state tests, his written language issues, and then his ACT coming up. You can go to, I think Levi's next. Oh, Levi, my sweet boy. So Levi is his identical twin, and he has cerebral palsy, epilepsy. He's got a feeding tube. He's non-speaking. He has cortical vision impairment, scoliosis. He's in a wheelchair, and he's had over 40 surgeries, and he is on medications, and has been during the school day, but is not currently. And so in elementary school, he did have a one-to-one nurse with him and a one-to-one para. And so he would have two people with him at all times. And so in elementary school, he was mostly mainstreamed, but he was a setting 3 kiddo. And so he would kind of bounce from his center-based program to a mainstream classroom. And he had his nurse and his para. So he kind of had this elite experience. But interestingly enough, his para and his nurse did not attend his IEP like meetings or anything. And then when he went into middle school, his one-to-one nurse dropped off, and his one-to-one para was now a shared para. And I thought, oh, that's interesting. I don't love that. But he did okay. And he was doing pretty good health-wise. And then when he went into high school, suddenly he's sharing a pair with 8 kids and has no access to nursing. And the nurse is calling me like 3 times a day. And so I didn't quite understand the difference in nursing. It was all the same district, and I didn't understand, like, how could we go from having a one-to-one nurse and a one-to-one para, and then suddenly now we're in high school and we have such a vastly different experience. And so I did have some conversations with the special education coordinator and explained, like, my child has not changed. My child's condition is not easier to deal with. And through advocacy, things got better. And so that it improved. But it did take communication, and it did take some parental advocacy. And when it come to making some changes for Levi as well, when he was younger, he did spend most of his time in the mainstream classroom, and he did seem to love that. And then as he got older, he did not enjoy that. And so what was best for him was to pull him out into a center-based environment as he got older. And that was just an individual an individual team decision that we made. And I think as a team, when that decision is made for what is the best interest of the child, that is important. When that decision is made, oh, we don't offer center-based for our children, or we are making all of our children do a mainstream environment, that's a big red flag for me. Services should be individualized. Um, but definitely he has seizure plan and all those good plans too. Yep, you can go. Go ahead. And I'll just chat real quick about Anna, my daughter. She is type 1 diabetic, ADHD, anxiety, and much more recently, an eating disorder that is connected to her type 1 diabetes, anxiety. And so she has had type 1 diabetes since she's 18 months old. So she went into preschool and kindergarten with that disorder. And she has always had a diabetic medical management plan. And when she got into about second grade, I pushed for a 504 plan. And the school pushed back saying she did not need one of those. And I pushed right back saying, absolutely, yes, she does. I was not going to settle for just having that diabetic medical management plan. And they did eventually say, okay, we'll make that a 504 plan. And as long as I was able to communicate that the why I wanted that 504 plan and that it was federally backed and that it would follow her, they were able to, kind of agree with the fact that, okay. And I think also being just an advocate for so long that they were okay with it. And I think a couple of years later, I think it was 2 years later, when Anna developed symptoms of ADHD and anxiety, having that 504 already in place where we could then just add those additional diagnoses, that was a helpful thing to have in place already. So we did, for Anna's diabetes, we did have a lot of nursing involvement. And we went through 2 different districts with her and her diabetes because she moved districts. And both districts were really great. And they did follow her on the Dexcom Follow app. And sometimes that's great. Sometimes it's not great. And I think with diabetes and being a parent of a diabetic, sometimes parents of newer diabetics kind of get a little bit too into like wanting kids in a very tight range. And I think there's also some nurses who get into that too. And sometimes nurses definitely and parents, if you're not on the same page, this is where that communication comes into play. If you're not on the same page and the nurse wants to have your kid in a too tight of a range for you, or you want to have your kid in a tighter range than they do, you're just on 2 different pages and you need to meet and get on the same page. And I think being proactive in having an expectation and just handing it right away in August saying, hey, this is our expectation. We're hoping to have our kid in this range, and understanding that these nurses have probably in a big school 20 diabetics that they follow. I mean, in a school that's got 500 kids, they could easily have 10 diabetics they follow. Right now, my kid's in a school of 2,000, and there's easily 20 diabetics in that school. And so in the beginning, we did have a nurse that was expecting a little bit too much. And they she did want our daughter in too tight of a range and was pulling her into the nurse's office a little too much. And our daughter is a very chatty Kathy and very quickly realized that during math class, she could chat that nurse's head off and miss all of math class. And so that became like a routine where our kid would miss most of math class because she would just chat, chat, chat. And so we had to communicate and say no more checking blood sugars during math class, and we just need to get this back into control.
So just a note here, we're at
Yeah.
8:01. I know we're supposed to be done at 8 o'clock.
Okay.
So if folks want to just hang out just for like 5 minutes, just to wrap it up, there's some
Yep,
really
yep.
good resources at the very end. So yes, just sorry, Kate, go ahead.
Yep, yep. And then we did have one accident that happened when we did have a nurse that accidentally primed the pump while it was attached. And what that does is it just gives too much insulin. And that caused, we had to take our kiddo into the ER. And when accidents happen, that's human error. And you just got to give grace. Human error happens. As parents, I have made accidents or made mistakes when giving my kids meds. And, it's hard to give yourself grace when that happens. But instead of getting angry, it's just best to try to understand and try to prevent it in the future and just give grace when accidents do happen. Um, but
And that's why sometimes it's so important to meet with the nurses and say, this is my child's, this is their device. I can share that, I came from hospital and clinic nursing. I don't have a child with diabetes. So when I went to the school setting, that actually was my first time manipulating pumps, because in the hospital setting, you give everything by insulin pen or syringe. So I definitely would always ask the parents, like, hey, please show me your child's device. And there are multiple devices out there. I also want to assure parents that um, there is actually a process if like a medication error would happen. So internally, there is, typically a medication error report is filled out. It's not meant to be punitive. It's more of like, what happened? How can we prevent this from happening in the future again? If it is thought to be a case of negligence or, not following the Nurse Practice Act or, the laws and rules and regulations, actually nurses are obligated to report another nurse, and actually school districts are obligated to report a nurse too. So there are safeguards in place too, where those things do end up getting investigated. But again, typically, like, it's meant to be in a non-punitive way of like, how do we prevent this from happening in the future? I just have a few things that I want to just shout out real quick, is that advocate in who you want to be at the table and part of your students' comprehensive team. So I think I mentioned before that sometimes like students who might have some school refusal or avoidance, and they might have a plan with the social worker, but we don't want the school nurse to accidentally undermine that plan. And so we need to communicate to the whole comprehensive team. And that might require you as the parent to make sure that that whole team is brought together and that no one's being missed in that communication. Understand your district's resources. You have to ask the questions. You just have to. Who's in your health office? Don't assume because there's a body in the health office that that is the school nurse. Ask if your school has a licensed school nurse. Sometimes it's a district nurse that sees it's a licensed school nurse for 14 buildings. When I was the licensed school nurse, I was leading 4 different buildings, and I had 2 buildings that had unlicensed paraprofessionals in my health offices and 2 buildings that had LPNs in my health offices. And we're a team. The health services were a team. So our LPNs or UAPs, they can't practice independently. So that communication has to include, for my kids, I communicate both with the health office. My son school has an LPN and my daughter's school has a UAP. She's a CNA. But I'll communicate both with the school nurse and the building nurse to make sure that everyone knows what's going on. So don't assume that because there's a body there, it's the school nurse. Ask the questions. Always assume positive intent. I think there's you as parents with a student or a child that has chronic health conditions and needs all the coordination and managing everything. It's exhausting. I get it. I've been there. But the health services team too, and teachers and social workers, they are also managing a lot of students too, and different periods of time in the school year. Think about the beginning of the school year, field trip season. There's a lot going on. And so sometimes district policy or procedures are what dictate why a nurse is doing this. So a lot of things we hear is like, I don't understand why the nurse can't just call the clinic and get my child's med order faxed over. Or I don't understand why I have to bring my medication, the child's medications to school. Why can't it just go in the backpack on the bus? So if you don't understand those things, ask the questions why. It's often due to district's policies, guidelines, and safety of other students. Again, sign the ROI. They're not asking for it to go behind your back about anything, but it is okay to set expectations. And I'll share just a quick story. I made a mistake as a school nurse. I had a student that we were really concerned about medications, this child having side effects. And I kept asking the parent, I said, and the teacher did too, we kept communicating, I think these could be side effects. I don't think this is progressive symptoms. Have you talked to your provider about side effects? Well, while I had that communication with the family, I communicated directly with the provider asking those questions, which I had an ROI for, but I should have CC'd or shared with the parents that, hey, I am going to be reaching out to the provider to express my concerns. So it's okay to sign that, but just like set those expectations of, if you're going to communicate with the provider, I'd like to know that you're communicating with them. And I would like to know what you communicated with them. It's okay to set those expectations. And then again, realize that nurses have regulations, laws, and rules that we have to follow. So sometimes our school routines might look slightly different than home. And then this is like kind of new. And just, I want to just throw it out there, but just a couple extra tips. Don't assume, ask questions about how health needs are met and communicated for before and after school programs, busing, and extracurricular activities. Most of the time, buses are contracts and they are not school employees. And so therefore they are not being communicated your students' health conditions or health plans. That's the parent's role to communicate that. Before and after school programs, they might be district led, but often that is not included in the typical school day. And so they very unlikely have a nurse available during that time. They might have a nurse consulting. That was how I got into. I was a nurse consulting for the after school program, but my role as a consultant was I was doing training. I was providing some guidelines and stuff. I wasn't available or on site at all the different programs. I was helping them to develop their programs. So ask how your child's needs might be met for those. And again, extracurriculars too. coaches, how are they getting communicated that information? Most of the time it's you communicating that information. Most of the time it's you sharing and training those staff on your child's health needs or the treatments and medications that they need. Lastly, I just wanted to touch on understand the ed neglect and truancy laws. When you get attendance letters, they sound really, really scary. I've gotten them. I've gotten them this year. I think we all got them during COVID years. I got them during COVID years with my name on it because I was the school nurse. Attendance is a priority. We are in an attendance crisis right now. The state has made it a priority to get attendance numbers back up. There is a lot of research about trajectory in school attendance. But as parents with students with chronic health conditions, we know that absences are not always avoidable. We have, our kids get sick. Our kids miss a lot of school because of appointments, because we can't get every single appointment outside of school days, or we just have that many appointments. When you get an attendance letter, just understand that, what is approved and what's an unexcused absence. This is reading your district's policy or and whatnot. Be proactive, get those excuse notes from the clinic or whatever. Sending those attendance letters is an opportunity for communication and partnership. Districts aren't sending them because they're like, oh, we're going to report you to the authorities right now. They're sending them because they just want to make you aware that, hey, your child's missed a lot. Unfortunately, staff don't have time to write the little cute notes on there I know my health assistants did. We're like, I know these are all excused, but I have to send the letter because this is our district's practice. So we just don't have time to do that. I think most of them are probably automated now. I get all mine through email. So the schools send them as just an awareness, and it's an opportunity to communicate and partner. And it's their strategy of okay, is there a need that this family has that we can help with, or vice versa? And then I wanted to share, this is reiterating from last week. You know your child. You belong in every conversation about their care. Be there, request to be there because you know your child best and you're their best advocate. You are the constant across sectors and systems. Education sector has so many different nuances than the healthcare systems. They're hard to navigate separately, let alone together. So you are the constant, and that matters. You are the communicator, and you kind of keep it all together. Ask questions and invite people to the table does not make you that parent. It's advocacy is one word, but it's demonstrating that you're curious and you're willing to learn and partner with the people. So ask those questions, but come at it from the curiosity perspective. Parents have power. Use it. Just like Kate said, if you feel that something's not being right, speak up, share your story, talk to the school board, ask the questions, ask the school nurse, how can I advocate? Talk to your legislators. Parents have more power than school staff. You don't have to do this alone, and you don't have to do it perfectly. Give yourself grace. We all make mistakes. Staff are going to make mistakes. We learn together. You are an expert in your child's health conditions and care. As much as you can learn from professionals, they can also learn from you. Humbly, I have learned so much over the years from the CNAs, how they explain things to patients, from my LPNs. We're all a team. We learn from each other. And I like to say it's layered learning. I hear something from one person one time, and then something triggers and it makes more sense later another time. So you are the expert. You can learn from the staff just as much as they can learn from you.
Thank you so much. The two, Heather and Kate, so you were so amazing. Thank you so very much for your time. Everybody who stayed up this long, thank you.
Yeah, thank you.
I know we went a little bit over, but this has been a fantastic presentation. really appreciate your time, both of your time. And if you guys have the ability to please fill out the survey to give us feedback on how we can improve this, to give us ideas on what we could be doing following this presentation, any other topics that jumped out as Heather and Kate were presenting, maybe you have some topics that you would like to dive in deeper. It would be fantastic to hear back from you, but please fill out the survey. We continue to offer this webinars through Pacer, and they're free of charge. And we improve those based on your feedback. So please do that. Have a great evening, everybody, the rest of it, whatever's left of it. And Heather and Kate, thank you so much. Jamie, thank you so much for your support, and we'll see you all later. We'll talk later. Have a great evening, everyone. Thank you. Thank you.
Thanks, everybody. All right, with that, I will end tonight's webinar. Thank you, everybody, for joining us.
Thank you.